Good afternoon. My name is Michael Shen. I hope you've all had a good lunch, or maybe you're going to eat afterwards, so maybe you're a little hungry, and that's actually better. I'm going to start this presentation. I work at Kaiser Permanente, by the way. I'm going to start this presentation with a fun fact about myself. This fun fact is that I am actually not allowed to play blackjack in this casino. In fact, I've been banned from playing blackjack at any MGM-owned property. And the reason for that is that I have a particular skill set, which is that I can count cards playing blackjack. And I've used that skill here a little bit too much. And so I've been asked to not play blackjack anymore. And for those of you who aren't familiar, counting cards at blackjack is basically a system of using numbers and data to count the cards that are coming out of the deck. And if you know the cards that are coming out of the deck, then you also know the cards that are still in the deck. And if you know the cards that are still in the deck, then you can adjust your betting for the cards that are coming out. And so many years ago, a few of my friends and I started learning this, and we started trying it out, and it was a lot of fun. And the reason why I loved it so much was that I was able to use basically numbers and data to beat the system, to get insight into something that was really hard to get insight into and stick it to the man, so to speak, which was a lot of fun. And basically, this is what my presentation is about, but instead of doing it in blackjack and making some money, it's doing it in healthcare and really raising the stakes to the point of helping people's lives, improving their lives, helping them live longer, and it is amazingly fulfilling for me. And that's what this project was about. It was a clinical transformation of how they did diabetes care, adding to it analytics that gave them that insight to continue to improve on it, to see how they were doing, and then in the end, having really great results in terms of improving control rates for diabetes. So that's what we're going to talk about today. So for the agenda, I'm going to introduce Kaiser Permanente and who we are, our group within Kaiser Permanente. Then I'll talk about the context. Why did we do this project, and what was going on back in 2016 when we first started it? Then I'll go to the solution that we implemented in terms of analytics and Tableau. I'll show some screenshots of the dashboards that we put into place for the different stakeholders. And then I'll talk about the results. What happened as a result of this transformation and the analytics we put into place, and did we make things better? And then I'll just kind of wrap everything up into a conclusion. So we are Kaiser Permanente. We have 12 million members across the country in 8 different states. And our mission is to provide high-quality, affordable healthcare services to our entire membership. And one of the ways that we do that is with an integrated delivery system. We have the hospitals, the health plans, and the medical groups all integrated together. And I can tell you, as a data person, this is a lot of fun, because I get to see all of the data, from lab results to membership data to hospital visits to primary care visits. It's all there for me, and it's a lot of fun to play with. So our group, we're in Orange County, so our little group services the Orange County area in Southern California. In our area, we have 600,000 members, over 900 physicians, 17 clinic locations, and 2 different hospitals, by the way, which are brand new and very nice if you have a chance to go to them. Our group is the Business Intelligence and Transformation Group. There's 4 of us right there. We actually added another member, so there's now 5 of us. 2 of them are here today, Stephanie and Mesley, so you can say hi, they're going to wave right there. And we provide the data analytics solutions for all of the Orange County service area. That's including all of the clinical data analysis, from inpatient to outpatient to ambulatory and all those different types of services. So why did we do this project, and what was going on in 2016 that started it all off? So before I go into even that, I want to give a short primer on diabetes and the terminology that I'm going to use. I know a lot of you probably are familiar with diabetes, but I want to give that to some of the people here who may not have that terminology. So first of all, what is A1C? So the full name is hemoglobin A1C, and it's a lab test that we use to diagnose and also monitor diabetes in our diabetic members. This measures blood sugar levels on average for the last 3 months, and the result is usually seen as a percentage. So you'll see it as like 8.5%. And by the way, that's not good. What is diabetes control? So you'll hear me talk about control and control rate, which is a really key measure that we use to determine how well we're doing with our diabetic population. And your diabetes is considered controlled if your A1C levels are below a defined amount. Generally, diabetics with an A1C of less than 7% are considered controlled. There are a few exceptions, but that's generally kind of the rule. So why is control important? And why is it a really key metric for us to determine if we're doing well with our diabetic population? It reduces the risk of heart disease and stroke. It reduces the risk of complications such as kidney disease and eye disease. It reduces the risk of mortality. And from a cost standpoint, it reduces the cost of care by $500 per patient per year. And that adds up, as you're going to see later on in the presentation. Another piece of context that is helpful is to understand our organizational structure when it comes to care management for diabetics. We start with our care leadership, and these are the folks who really started this whole transformative process by saying we really need to change how we're doing it. But they're also the people that manage our care managers. And we have 27 care managers across the Orange County area. These are really hardworking nurses and pharmacists who take care of our diabetic patients. They work with over 300 primary care physicians, and those primary care physicians support and care for 42,000 or over 42,000 diabetic patients in Orange County. Those primary care physicians work in 17 different locations. But really the key and the key to this presentation today is our care managers. They are really the key to diabetic care. They're the primary point of contact with our diabetic members. They really guide the medication that they take, and they also advise them on lifestyle and how to eat better, exercise, and improve their condition. They also coordinate one-on-one with their primary care physicians to strategize and provide a total care perspective for those diabetic patients. So now on to the context. Why did we do this project? So back in Q1 of 2016, diabetes was a major challenge in Orange County. We had over 42,000 diabetic members, and our A1C control rates were stable, but they were stagnating. We had a 75% HEDIS rating in terms of glucose control, which is good, but it is not great, and we're used to being great. Also, our PCPs were overburdened, and they were really lacking support when it came to working with our diabetic patients. So our goal was, let's transform this good to great. So in Q2 of 2016 came that decision. So our care management leadership said, let's transform diabetes care. So what they did was they researched and designed completely new care workflows. Those care workflows focused on the engaged population. They designed tighter collaboration with primary care physicians. And they created a closed-loop workflow to ensure nobody got lost. And then they also wanted to track and monitor the productivity and outcomes of our care managers and of the populations that they care for. So in Q3 of 2016, they deployed those new workflows with our care managers and our primary care physicians, but then they sat back and they said, but how do we know how we're doing? Because they really didn't have good data to see what the results were and how to improve on it. So in Q4 of 2016, they came to our group and they said, help us develop analytics for this. So we worked with them to define analytics requirements for this project. So what were those initial requirements and goals? So first of all, care manager operational performance. So they wanted to track two key metrics that were part of this workflow change. One of them was turnaround time. So that is the time it takes from a diabetic's A1C lab result to come in and the time it takes from that until the care manager has resolved that A1C result, which means have they called their member? Have they worked with them on how to adjust to the new result? And the faster they could get to that, the better. The second one was called momentum. There are actually a few operational metrics, but these are the key two of them. The second one was momentum, and that is a measure of, okay, now that you've called them and you talked to them, how often are you doing something substantive? So how often are you ordering their next lab result? How often are you titrating their medications? Because those are important metrics as well. And so they wanted to be able to compare those metrics against different care managers, the entire care manager staff, and they wanted to be able to trend that over time so they can see if they're improving or they're doing worse. The next requirement was then, okay, now we know operational metrics, now we want to see outcomes. Are these workflow changes and operational metrics resulting in a healthier population of diabetics? So that key metric is, again, going back to control rate. Are the control rates for each care manager, so the panel that they are responsible for, are those control rates improving, and can we track those control rates over time and compare them against different care managers in the same way we're comparing operational metrics? And the last thing was being able to give care managers direct feedback and actionable insight. So it's one thing for the care management leadership to see how they're doing, but it's a completely different thing to be able to then share that with the care managers and allow them to act on it and make decisions that improve their performance. So could we give them a scorecard snapshot of how they're doing? Can we give them a patient list that prioritizes that list of patients so they know who they need to focus on and who might be getting dropped off their radar? And better collaboration with their PCPs, allowing them to have better conversations with those physicians. So we'll look at the solution that we ended up implementing for them. So starting with the care management leadership as our primary stakeholder, in Q1 of 2017, we deployed the Care Manager Operational Performance Dashboard. So these were those operational performance metrics, the A1C turnaround time, A1C momentum, and also a list of all the current open results that may need to be individually tracked. In Q3 of 2017, we deployed the Care Manager Outcomes Analysis. So this is now relating those operational metrics to actual outcomes of the patients. How is each care manager's panel of patients doing and improving over time? In Q1 of 2018, we then deployed a dashboard that's just for the care managers themselves. So now they can log in and see how they're doing and have a list of patients that they might need to focus on. And in Q3 of 2018, we deployed clinic outcomes performance, which allows each of our clinics and their leadership to see how those individual locations are doing over time. So before I show the actual dashboards, I want to give a little bit of background into the architecture of how we got the data into the shape so that they can be put into the dashboards. So our data source, our main data source, is Epic. So we have Epic as our EMR, and we have the Epic Data Warehouse, which they call Clarity, and we pull data from there. We also had to create some reference tables to help us along with the data, and the primary one is the care manager to primary care physician relationship. So each care manager is assigned multiple PCPs, and we have to keep track of who's assigned to who so that we know what population they're in charge of. So for the operational metrics, we just created views on top of the Epic database. And those views feed daily extracts in Tableau, and those daily extracts feed our operational metric performance for care managers. For the outcomes, it gets a little more complicated because we have to understand who our membership is and who's diabetic. So we use Alteryx, actually, to do the ETL work. The first step is getting member months. So understanding who is a member of Orange County over every month for the last 2 or 3 years that we're tracking. Then we go to the diabetes calculation where we're saying, okay, these are our members, are they diabetic? And let's pull some clinical information about each of those diabetics for each of those months over time. Then those ETLs feed some data mart tables that we built, a diabetes monthly aggregate table, and a list of current diabetic patients. And those have views on top of them, and those views feed daily extracts, and those daily extracts feed our outcomes dashboards. So I'm going to show you some screenshots of those dashboards. So I'll start with the first one we deployed, the operational performance dashboards. So this view is the turnaround time view. So this is what we talked about in terms of how quickly are the care managers responding to A1C results, and this is measured in days. How many days does it take? And on the right-hand side, you see a list of all of our care managers and a heat map of their their monthly turnaround time on average. Green is good, and then yellow and red gets worse. So we want to be green, which is good. By selecting an individual care manager, we get the drill down on the right-hand side. And the right-hand side on the top shows their monthly turnaround time over a 12-month period. And the bottom one shows their total volume of A1C results that they are working on over a 12-month period. And that bottom chart also breaks it out by those that took over 5 days to respond and those that took under. So those red little bars are those that took over 5 days, and that could be problematic, and that's something that our leadership might want to focus on. The next view I'll show you is a view that shows all of the currently open A1C results that have not been resolved yet, ranked by care manager. So that bar chart on the left-hand side shows the care managers with the most open A1C results. And again, the red ones are those ones that have been open more than 5 days. So those care managers with a lot of big red bars probably have some issues, and we need to work on them. By selecting one of those bars, you can drill down on the right-hand side and get the detail for every single one of those messages, and then you can be able to triage those messages and see what needs to be done. So we'll move on to the outcomes analysis, and this is looking at the control rates of the care manager panels. So again, it's a similar type of view. You see the care manager list on the left and a heat map of how they're performing, but instead this time what you're seeing is the control rate. So the control rate, again, is the percentage of patients who are underneath that 7% A1C result. And the higher the control rate, the better. Ideally, 100% of our diabetics are in control. So blue is good here, and orange and red is bad. And again, if you select on one of the care managers, the right-hand side drills down. You'll see their control rate trending over time for the last 12 months. And on the bottom, it shows you the size of their total diabetic panel broken out by those who are in control and those who are out of control. A couple little details about this chart that might be interesting. So one thing that we did here is we can actually flip the metric that's being shown in the heat map. So by default, it shows A1C less than 7. Excuse me, A1C less than 7, but by selecting a different metric, we actually, using parameters, we can change the metric that's being shown in the heat map to A1C less than 8. Here we're using table calculations, so instead of just showing the static control rate, like 45% or 46%, this one will actually show, by switching it, you'll see the change in control rate for the last 12 months. So again, that's using a table calculation to say, starting from 12 months ago, how much has the control rate changed for each care manager? That helps us understand, okay, they might have a difficult population, but how are they changing that control rate over time? And another thing I'll just point out, it's a minor thing, is sometimes we use these little cards in dashboards, especially with a more complex topic that not everybody who sees it might understand. And it helps describe what's happening in the dashboard. It's kind of a lo-fi way of just having some annotations in there that describe and help our users along in terms of navigating the dashboard. Another view we have is a geographical view. So this is all of Orange County, and now we're showing control rates bubbles by location in Orange County, and which locations have worse control rates versus better control rates. And you can see for Orange County, those of you who are familiar with the area, our South County areas tend to be worse, and our South County areas tend to be better, and our North County areas tend to be worse. And that's based on demographics. And what this really helps us with is when we assign care managers different populations, it's good to know the demographic and the demographic context of the population so we don't really penalize care managers for having a tough population. And then you can drill down in the bottom side to see all the primary care physicians in those locations and ranking those primary care physicians by their control rate. So this chart actually changes how the data is being shown. This is a newer item that we added in. It's called A1C controlled churn. And the idea is that it's sometimes difficult to tell how you're doing if you're just looking at a static control rate. Because you can have a challenging population, or it's just difficult to work with that population. So what this does is it measures how many diabetic patients are our care managers changing from out of control to in control and vice versa, and providing the net count of positive changes that happen. So in other words, I've had 10 patients that dropped from in control to out of control, but I had 90 that went from out of control to in control for a net improvement of 80 patients. So that shows that metric for each care manager ranked by those doing the best to those doing the worst. And again, you can drill down by care manager and see the monthly trend of churn rate over time. So the next thing I'm going to show is the individual care manager view. So these are the dashboards we developed specifically for the care managers to be able to log in and check in on them themselves, see a scorecard of how they're doing and how they're performing, and get a list of patients that they need to probably be focusing on. So this is the first view they see. It's the scorecard. And it gives them a high-level view of their overall population and how they're doing. When they come in here, they can select on themselves. There's a list of care managers there, and they can select on themselves to see how they're doing. But what is interesting, in the care manager leadership expressly wanted this, is that they wanted the care managers to be able to select on any care manager and see how any care manager was doing. Because what would happen is this allowed the care managers to actually communicate with one another about where they might need help. So if one care manager wasn't doing well, they would actually see them talking to a high-performing care manager and say, what is it that you're doing that I'm not doing, and how can I improve? Once you've selected a care manager, you can further drill down to the individual PCPs or primary care physicians that those care managers care for, and then you can see just the performance of that care manager and that primary care physician, or just see a single care manager. On the upper left, you see some cards that show some big numbers. So you see a care manager's diabetic population size, the total control rates, the current control rates that they have, and the current number of patients that are out of control. On the right there, you see bar charts that show the demographic breakdown of these populations by age range and also by the location where they're stationed. And the bottom is the real money charts, and that's where it shows their control rate trending over time. And this breaks out their control rate by the different age groups, because it's important to understand your control rate by seniors versus lower age members. So the orange is your seniors, the blue is your lower age members, and the gray is everything combined. And so you see on the left is the A1C less than 7 control rate, but sometimes they're going to want to see the A1C less than 8 control rate, which is also something that we get measured on from time to time. The chart on the right is actually quite important. We haven't really talked about this. It's the screening rate. So this is how often or how many of our members are actually coming in to get screened when we ask them to come in, because there are members who just don't do it. But for us, it's important. The higher the screening rate, the more likely it is we're going to get them into control. So it's really important we try to drive up the screening rates of our population. So we give them this view to understand if they're doing well or not doing well in terms of screening rate. So the next view, again, it's by the care manager and primary care provider that you select, breaks that population down by demographic. And one of the key real initiatives by our executive leadership, and remember, we're in Southern California, we're in Orange County, and a very challenging population for us is the Latino population. Traditionally, they have lower control rates than the rest of the population, and we really wanted to focus on the Latino population to help them drive control rates up. So what this view allows our care managers to do is to see how they're doing with their Latino population. So that bar chart breaks down the number of patients that are Latino by different age groups. You then also see the number of patients by their primary spoken language. So we have a lot of patients that their primary language is Spanish. And then those trending charts on the bottom are similar to the ones that you saw before, but now they're breaking that out by Latino and non-Latino population. So the care managers can now see if they're doing well or need help with their Latino population. The next view is a patient list view. So for each care manager, this is a list of all of their diabetic patients ranked by the jump in A1C result since their baseline result, which is the last one that they took last year. So those who jump the highest are ranked the highest on this list. And so that would be that bar chart on the right-hand side there. So this allows the care managers to see those patients ranked by those of a certain type of need, which is they've jumped really a lot in A1C result. Are there any patients on this list you're not keeping track of or need to focus on? We provide some additional information in the columns, like when was their last PCP visit, did they miss their last PCP visit, and what were their most recent A1C scores. They also have the ability to filter on this list in a lot of different ways. They can filter by whether they're Latino or non-Latino, their age group, their last A1C score, whether they have a PCP visit or not, all the different filters that actually came out of working with the care managers and the leadership on what they like to see in terms of filtering. The last thing I want to talk about in terms of the care manager dashboard is what happened when we deployed this to them. I keep pressing the wrong button, sorry. Hold on. So the care managers, by process, have a monthly or quarterly meeting with each of their primary care providers. And this is a meeting to discuss their strategy in terms of how they're going to care for their diabetic patients. Before this, they spent a lot of time trying to collect data about their patients, and they really didn't have a lot of information to go on. So now with this dashboard, they actually print out the 4 key views in this dashboard, and they share those with their primary care providers. I know this because whenever the dashboard is delayed, I get a lot of calls from care managers saying, where's my dashboard? I have a meeting today, I have to print these out. But it's been really helpful for them. So they go to those meetings with these printouts, and they work with the physicians on a strategy to make sure they're caring for their diabetic patients, and they go through that list of patients to make sure that there's not a patient that they've forgotten about. So that was the views of the dashboard. Now I'm going to talk about the results. What came of implementing all of this stuff? So first of all, operational improvements. Time savings. So they saved at least 12 hours a month collecting data, building reports that were, by the way, not what they needed, but at least they had something. Care manager operational performance, they reduced their A1C turnaround time from over 5 days to about 1 day. They increased their message volume completion by 10%, while also maintaining an average of 40% momentum. And again, momentum is how often they're actually doing something, titrating medications, ordering labs, and 40% is the target that they're trying to reach. A couple testimonials. Our director of complete care, Irene Shea, she said, "It is one of the most important tools that we have to hold care managers accountable and improve the quality of lives of our members." And one of the care managers themselves said, "By visualizing and pinpointing trends, I can address issues in my diabetic patients before they worsen." And that's a really great thing to hear, is that they're actually using this to prevent things they know will happen down the road. But what's more important is the outcomes. So how is our population actually getting healthier? So we have those operational improvements, and one of those key ones, again, is turnaround time. And you can see back in 2017, after we implemented the new workflow, our turnaround time went from 5, 6, 7, 8 days down to about 1 day over the course of 2017. So that led to a change in actual patient outcomes. So our A1C control rate, which is the percentage of patients below 7% or in control, rose by 3% over that same time period. That's 1,200 diabetic patients who previously were not in control who are in control now. And that was 2017. So then what about 2019? What about right now? Oh, I'm sorry, I skipped ahead. So in 2017, for the first time ever, Kaiser Permanente in Orange County achieved that 90th percentile rating in the HEDIAS NCQA glucose control rating, which is what we were trying to achieve to get that greatness. So what about 2019? So going back, you can see the control rates are steadily improving even through 2019. And our A1C control improvement has increased by 9.3 percentage points since we started this project back in 2016. Some of you are going to notice that dotted gray line in the middle where there's some missing data. And that's unfortunate because what happened was our vendor for A1C labs did a reagent change, which means they changed the formula for their results. They actually did it twice in that 1.5-year span. The first change artificially reduced control rates, and the second change artificially increased control rates. And it really shook up the data a little bit. And you can see it, I'll show it to you. That's what it looks like. So you know something's going on here. That's not real, right? So it was unfortunate because I really want to know what that data looks like, and I can't because of that pimple of data that we have there. So going back to this, but it is clear in the last 6, 7, 8 months, we're showing a multi-year trend of improving control rates in Orange County. And I'm just going to overlay the dashboards that we implemented during that time frame. So to wrap things up, since 2016, we have reduced A1C control rates by, we have increased A1C control rates by 9%. What does that mean? That's a shift of almost 4,000 diabetics that are now in control. That's an estimated cost savings of, annual cost savings of $1.9 million. But beyond that, what's most important is it's thousands of lives that have been positively affected. Thousands of lives who are living healthier, who are living longer, who are doing more things that they couldn't do before. And that's really the most fulfilling thing of doing this work. And the last thing I want to say is I think there is a perception in this presentation that maybe, oh, because of these analytics, it's all because of the analytics that this happened. And it's not true. It was a team effort. It was really the clinical leadership that said, we need to change how we're doing things. And they put in place these new workflows. But we were the ones that put in place the analytics that helped them understand how the workflows were doing and how to continue improving while those workflows were in place. And one couldn't have done it without the other. And it's really a team effort, and everybody wins in this situation. So that's kind of the overall takeaway from this. So what's next for this project? This project doesn't end. I get requests from that clinical leadership all the time for new things. And so here are some of the things that we're going to look to do in the next few months. A patient snapshot view. So what this is going to allow our care managers to do is to bring up an individual patient and collate a bunch of clinical diabetic-related information into one area. So they can get a view without having to dig around in our EMR system for a long time. It's really going to save them time in preparing for visits with our patients. We're going to add some predictive analytics to try to predict when patients are going to churn. what is the risk of an in-control patient about to go out of control based on a host of different clinical factors. By doing this, we're going to help our care managers prioritize what patients to focus on first to help them stay in control. And the last thing we're going to add is care manager workload balancing. There are care managers who are working really hard. We're going to track the amount of visits and calls and emails and things that they're doing so that we can help the leadership balance their workload better so we're not having care managers burn out from too much work. Last thing I'm going to do is I just want to thank our key contributors, our top-level leadership, Dr. Nancy Jin and Dr. Todd Newton. They are incredible in their push for innovation and always doing things outside the box. The clinicians who led this transformative change, Dr. Wu, Dr. Koling, Irene Xie, the Director of Complete Care, they were the ones, it was their idea. They put into place, and they get a lot of credit for transforming us. And then the last two are my bosses, and they are amazing, and I just want to pimp them out a little bit. They do great work. They're always allowing us as a group to try new things, to innovate, and try to really come up with new ideas how we can solve problems. So I really want to thank all of them for their support. And that's it. I really want to thank you guys for listening to my presentation.